I guess I was curious how you all are approaching the difference between relaxing of restrictions versus increased risk behavior with like complacency over time, with people kind of just getting used to what's going on and kind of maybe getting tired of what's happening.
So the way we approach is basically having a reduction on transmissibility. And the way we are modeling the reduction of transmissibility is reducing the number of effective contacts or social contacts that people have between or across different age groups. So if we have some estimated values on number of social contacts under, let's say, status quo or steady state, like under regular conditions, and we say once we implement these non-pharmaceutical interventions on reducing, let's say, isolation or shelter-in-place strategies, we say how much that reduction in effective number of social contacts that has to be in order to see what we are observing. Yeah, so it's basically reducing effective social contacts, and that's basically modeling the change in behavior.
And so with the change in number of social contacts, does that matter if mask usage is different? So like, I guess what I mean is like, you know, if restrictions are lifted in terms of shelter in place, there's going to be more contacts, but people may be more careful and wear masks, as opposed to complacency where it's kind of more of like a function of time as opposed to like a discrete event where restrictions are lifted.
Yeah, no, that's a great point. And that's why I mentioned effective number, like number of effective social contacts, because even people may have more contact, but the effective contact, what we mean by effective contact is a contact that if an infectious person is in contact with a susceptible, that contact would yield potentially to an infection. So even though they have the same interaction, same distance, and even same amount of time spending, but wearing masks, then that social contact might not be an effective one, or one of them might not equal one of or not using masks. So it has to be 2 or 3 of those in order to equal what would happen without using masks.
So just to add to that, so because it's a contacts times probability of transmission given the contact, the multiplier could either be reducing contacts or reducing the probability of transmission given a contact. And from the model's perspective, it doesn't know, and it's sort of equivalent for the force of infection. And in the modeling structure that Fernando and group have developed, that multiplier is time varying, right? So if people are going out more and simultaneously not masking, then the multiplier wouldn't be as powerful of a multiplier. If they're going out more, but they're masking to offset it, it could be the same. And if they were like, you know, even becoming more careful, it could actually be an even stronger multiplier kind of thing. And we let the data on cases, recent sort of trajectories on incidents inform that essentially, right?
Mm-hmm.
I mean, would you, I think that's an accurate characterization. I don't know.
I agree. Yeah.
Great. Thank you.
So I don't know if more folks are going to join, but I don't know, Matt, are you involved in any COVID-19 activities or focusing on transplants?
Right now, no, I haven't been involved in any COVID modeling. Mostly just trying to work on my research that's going to help me graduate, and also
good idea.
yeah, and then also you know, I've got a full course load still, so but yeah.
And what type of modeling techniques you're most interested in?
I do some like microsimulation in terms of the transplant modeling that I do, and also eventually plan to add some kind of waitlist dynamics. So trying to learn a little bit more about queuing theory. And then I'm actually taking the course that you're doing with Ava with calibration in a couple weeks. So
yeah, cool. Are you also an R user or?
I use Python primarily right now, but I know R and I use it for other classes, so I kind of go back and forth.
Cool. So hello, Aman. I see you join our breakout session. Welcome.
Thank you. How are you, Orlando?
All doing good, thank you. Yes. So we were discussing about some of the modeling specific details of our approach, but I don't know if you would be interested in or have any specific questions or would be interested in the work that we are doing. Or if you want to
I
tell
don't
us
want to
about
interrupt the flow of the conversation. Please do continue, and I'll jump in with my questions.
Yeah, no, we're actually having just like relaxed conversation. We're at a point that we're welcome to have new questions. So go ahead.
Well, I guess I'm particularly interested in the work that you've done with your decision makers to really understand what their process might look like. And so the parts of the conversation that were particularly striking to me is this this sort of, the process by which Mexico, I guess a COVID response team or some sort of committee might have come to you and said, here, this is what we need. And then you talked about a little back and forth where they asked for a nationwide thing and you drilled down to a state and local. I'm curious how intentional this process was. Like, could you sit down at the beginning? Did you have the opportunity to really think about, well, what are the decisions you'll have to make, and can we help design an approach for you that would really help you make those decisions? Or was it very reactive where they just asked you for stuff and you did your best to deliver on those things and hopefully provided the benefit they wanted?
It was that's a great question, Aman. So I think it's a mix of both. So at the beginning, they wanted to have national level estimates on what the course of the epidemic would look over the next couple of months. That will happen in late March. But I had this struggle with them saying that it's difficult to, if I build we have the model, so I can just, and we had a country level model, but the projections of that model might not be as informative because, as I mentioned, different states might be at different stages of their epidemic. And that's what be happening. So I pushed back and say the best that we can do, because we didn't even have all the data for the country to, like the state-specific data to come up with state-specific models and then aggregate. So at best we had for a handful of states. So I said, why don't we focus our efforts on modeling Mexico City and do some projections for Mexico City, which Mexico City has been the state that started the earliest and still in there hasn't slowed down the epidemic basically. So we say we're going to provide some results. Now there were other teams, and the idea was to do some comparative modeling. It didn't work as expected or intended. And at the time, other models presented results, quite optimistic results that seemed that the epidemic would not last as long. And then some decisions were made based on the different results. And we were part of that conversation. But one of the least optimistic model results were ours. And once they saw that the optimistic results didn't materialize, then they started reaching out to us saying that it would be willing to help them. And eventually we have been able to populate different state-specific models to then be able to do a national level projection of the epidemic under very wide on overall MPIs or different mitigation strategies. But they've learned also that it's very important for model teams to illustrate and be open about their assumptions. So once an important assumption at the time was the case detection rate. And we would ask how many of the people that you detect or the cases that you are capturing, how many do you think they're in the community that are infected? So for each of the cases that you detect, how many do you believe are infectious at that time? And right now we incorporate that inside the model, but at the time we were doing these different scenarios. What if it was 1 in 10, 1 in 20, 1 in 50, 1 in 4? How the results would look like based on those assumptions, because we did not have still much idea about what would be the quantity. And we're very open, and we just provide all these different scenarios. And but they only wanted one number at the time. They wanted one number that they would operate with, and then they realized that it's not that it's just going to be one number. It's like a range of possibilities based on two things, at least: uncertainty, which is like how much we know about these different dynamics, but also scenario specific. What if those values of parameters we don't know about? Then we should do a what if scenario, a scenario analysis. Is what if it's like high value, a low value, or this is the scenario or the other scenario? Come up with ranges or different scenarios of estimates, and then see whether any under those different assumptions, strategies could yield some surge of the hospital capacity or whatnot. So
Yeah.
I think there's also been a learning process both ways.
That's really helpful, Fernando. Thanks for sharing that. And I think that makes a lot of sense. It's always a challenge, you know, when you go from getting an output as a number to getting a range to getting scenarios, and then trying to translate that into a decision. You have to change the way that you make the decisions. You can't just say, oh, this is the number, therefore this is the decision. If you end up with a bunch of scenarios with a collection of outcomes for them, then from the decision-making perspective, how do you then take that into you know, back to a policy decision or, you know, about an operational decision? And did you get much insight into that?
I mean, most decision makers that I can't say for states of Mexico, but most of the conversations that we've been having with decision makers in various parts of California government, they're not looking at only one metric.
Right.
And there is this challenge of how decision makers understand uncertainty, but at the very least, even without uncertainty, they're making a whole number of trade-offs. I mean, the fundamental one is the obvious one of kids out of school versus deaths and hospitalizations and overwhelming health system. And so they're already considering those things, and they're considering you know, California's sort of publicly propagated set of like reopening criteria involve equity kinds of measures and process measures and other kinds of things. So like other than at an extremely sort of narrowly kind of tailored decision maker. So Lauren Cipriano is dealing with hospital decision makers and their decisions about kind of whatever, and that's a kind of different context. But once you're sort of into even a relatively small geography kind of general decision making, they're already doing that. The uncertainty piece is tricky. I think that from a variety of contexts, non-health generally, people are sort of kind of familiar with risk to a certain degree, although it's often sort of like financial risk or those kinds of things, and you know, nobody likes it. But I mean, we were getting questions like, you know, can you tell us kind of what's the higher end of the 90% range, right? I don't know. I didn't do some tests to see how they understood that precisely. But the way I took that was they wanted to plan for kind of things that might be worse than what the expectation is and be able to sort of feel like they could handle them. And I don't know. I mean, I know there were some wide, especially because in Mexico, you guys were being asked to kind of project pretty far out relatively early on. So you must have had conversations about that.
Yeah, I mean, what was when we showed them these ranges, we said in early May, we expect that it will not reach its peak until like late July, beginning of August. And at the time where we're like some other model results were like it's gonna peak in 2 weeks. So it was a difference between of 2.5 to 3 months where we would think it would get the worst in the epidemic. Obviously, assuming that, for example, current social distancing will remain in place. And that's the other, like if projections didn't happen, then they would say, oh, it's because people didn't adhere to what we kind of like were expecting. But that argument was very tricky because they would say, oh, it didn't peak in 2 weeks because people started going out. And then like population believed, or the population believed, oh yeah, it makes sense, like we disobeyed or whatnot. But if you think about it, it's also a nice thing about the models. What would happen if people don't adhere to this recommendation? It's not that the peak is gonna go further out. It's actually gonna happen sooner. So, so having these conversations also helps them understand the model.
The last thing that they want to do that where actually uncertainty actually is helpful is, so there are discussions sometimes about, you know, we're considering reopening X or Y or Z, right? And there is some concern there because there's uncertainty about what's going to happen if you do that. And a question that the models can help answer, which actually is this uncertainty kind of thing, is, okay, when and how big would you start to see, would you be likely to start seeing signal if things went off the rails, right? Because you're going to get some stochasticity jumping up and down in terms of what's happening. There's some range about what might happen, even if things are, even if it's behaving as the model sort of predicts. And you can actually use that uncertainty to kind of be able to sort of share something like, you know, if you got a case count from some sort of measurement on some day that was this big or bigger, it's very unlikely that things are behaving as we're expecting, right? So in that sense, the uncertainty then actually turns into an advantage. You know, it's like, when do we need to start freaking out? Take care, Matt. And what additional measurements might we want to be taking to have an early signal of whether we should be freaking out or whether we can kind of increase confidence over time as we sort of see things going the way we're expecting them to. Yeah, right. I don't know. I mean, Fernando, did you, when people saw epidemic patterns, did you start getting questions like, you know, how come it's like this instead of like that? How come we aren't seeing these things in our actual data? Yeah. Those sorts of things. Yeah, and then you can use the model to help.
Mm-hmm. Yeah, and also like we release projections widely, and several like national level newsletters picked it up and some media. So I was like on the media quite a bit explaining our projections, and they were asking, why, if you relaxed NPIs on a given date, why would cases go up? And why would like different dynamics would occur given different mitigation strategies? So that's also helped me to, well, this opportunity was like, oh, because when you really, there's still like, think about it as a big flow of water. You have a big bucket of water. So you start opening the faucet, like opening the spigot. Yeah. So, but then if you close it for a bit, the water's still there, right? So once you open it again, it's gonna come out, and depending how much you open it, it's gonna come with greater force. So it was important to understand, or even like the reporters wanted to understand these like different modeling results, and I had like these conversations with them on what we should expect under different strategies, and why what it would represent for the epidemic to be over in a month, for example. It would say, oh, we are predicting that in a month it is going to be over. What does that mean in terms of, for it to be over, there's a certain amount of the population that needs to be infected by then, so it to be over? And is that like really feasible that so fast everyone is gonna get infected, given what we know about, for example, R0 at the time and whatnot? So it was not really like credible it's gonna end as fast as some models were predicting, or what would the assumptions need to be for the epidemic to end so fast, and whether those assumptions should be realistic. And that's the power of another power of the model, or of models.
Another thing that we were able to kind of do is, you know, when the second wave of cases occurred, there were questions about why hospitalizations and deaths didn't jump as quickly, right? This was a question in various parts of the US. And one of the things that you could actually do, because the model framework that we have is age structured, is sort of talk about the fact that as more cases, as the average age of the case shifted younger, right? And since young people themselves are less likely to be hospitalized or die, all else equal, then they had to generate a second generation of cases in older people to see the sort of bump in incidence lead to a bump in hospitalization. So you can explain the differential timing and sort of talk people through that. You know, this is why, you know, it's not that we're seeing incidents, we're not seeing a rise in hospitalizations right now, but actually we'd expect to see it in about 3 or 4 weeks. And we can have that conversation that actually build trust, because guess what, in 3 or 4 weeks we saw a bump, and people, you know, and then we can go back to their data and actually do you know, analyses. I mean, Fernando's done this with Mexican data, and I've done this with California data, is like do survival analyses and talk about how the you know, how age explains a big chunk of the timing of these things.
And even like the behavior of people seeking hospitalization. Mm-hmm. So there's all this in the news in Mexico, that people that would get to the hospital would like have a higher rate, mortality risk or mortality rate just by attending the hospitalization. And there was like this changing behavior that people would stop going to the hospitals. And so if you analyze the probability of hospitalization or how likely were affected cases to get hospitalized over time, so that would change, and try to understand that and not just having a fixed parameter. And that's another one. At the beginning, the best that you can do is getting data or transfer data from other settings or evidence. And then you can test how transferable was that evidence at the time. And then at what point you start shifting or putting less weight to evidence from other settings and put more weight to evidence coming from the setting you're interested, assuming that the quality of the data is good enough for you to use it, and eventually just get rid of the external evidence and start like generating internal evidence for your model and start using that to make predictions. And also be an interesting experience doing that. So
in honor of Scott Cantor and Sue Karaoke.
So is this like a warm-up session of karaoke? I mean,
I got to get the music, man, you know.
Hi, Scott.
It's great to see you. I came in late. I wanted to hear the other two, but I just really wanted to say hello, Fernando, and it's a nice surprise to see Jeremy and to meet Valeria and Aman and Andrea and support as well. So it's
Aman, where are you based?
I'm usually based in Oakland, California. I'm currently in Colorado.
Gotcha. And what do you do?
I work with developing basically academic data tools into products for decision making. I'm working with the Rockefeller Foundation at the moment. So yeah,
cool.
I'm particularly interested in how these sort of data models and tools get translated into decision-making frameworks and how people are actually using them and interacting with them to drive policy decision-making in COVID right now.
Yeah.
And your thoughts are very helpful and useful. So thanks, both of you.
Yeah, no, thanks for joining our breakout session, Aman.
And the other thing that happens is that some of the early modeling, especially if you talk about early modeling in a relationship with decision makers, if you properly contextualize it as not being kind of hyper definitive, is an approach where you can help them get comfortable with you, but also to unlock other data. Sort of to say, like, here's what you can do with the model that we have given the data that you've given us, and here's what's we're not able to comment on because we don't know that. So that's been Fernando and team, and our team has been working with California Department of Corrections and Rehabilitation. So we basically get a daily data feed of everybody who's incarcerated in the state prison system here. So it's 100,000 people. You know, there's a trust relationship that needs to be built up there. And we're just sort of like, there's going to be another even wider tranche of data that will essentially enable us to kind of not only think about inmates, but also sort of the kind of correctional workers and the communities that sort of surround them, because that will help to answer some of the questions that, or to provide information to go into some of these questions. And it's clear that the model doesn't give the answer, right? Like these are just like another way for people to kind of, you know, regularize their thinking and et cetera. And, you know, have conversations and ask what if questions and all those other sorts of pieces. But it's definitely, I mean, like, I don't know, like, I think Fernando, in a couple of your situations, basically data got unlocked extremely quickly, and in other ones it evolved kind of over time via relationships and and
so that's a good point, because at the beginning of the epidemic, when we got like someone to help out with these modeling efforts, we said, okay, what data do you have? I mean, it's not just like build the model and just put parameters and that's it. So if we're going to implement it for Mexico, we need to know like the composition, if there's some estimates on social context, for example. We had to take a deep dive into the literature to go get those, but more specifically, it's like how much cases we're getting. There were no information. And based on the conversation that we had in late March, is like, it's important to have this data, and that also helped out to put them out. So every single case now is released daily by the federal government. So we say, what is the type of data that we need to inform our models? So they put together some data and say, okay, this is good, but still not good enough. Are you able to like get this more information, the date of confirmation, date of symptom onset, when they got hospitalized, whether they died, when did they die, and sort of make a big effort to do this follow-up and going back and forth. And even though we were not part of the data curating team, we're doing a lot of data curation and understand whether the type of data we were getting was good enough and whether they were doing like the best job they could. So it took us quite like several days over several weeks to going back and forth whether that data is enough before we would even be able to do any modeling, estimation and projections. So that also was helpful, I guess, for authorities at that time. And also the state.
Fernando and I actually at times have advised people to go with different modeling approaches because of the availability of their data. So we dealt with an Eastern European developing country that was interested in doing certain types of modeling, especially around their incarceration system. And one of the reasons that we sort of kind of advised them away from sort of trying to kind of implement what we had done and sort of to some kind of simpler approaches was their available data just didn't support it. It wasn't even about organizing it. It's like they wouldn't have it even if they had people to kind of go and kind of collate it together.
Yeah. Well, I think you're hitting on some really interesting points here, and you know, the conversation that we've been having on my team is related in the sense that a lot of the really important work that's happening involves a kind of back and forth and deep integration of trust and so forth that you've been talking about, and there's that layer. But the volume of demand that we're seeing right now is at a whole other layer where for every one per team that you're working with that has the ability to work with you at that level, there's 100 teams that don't have the ability to work with you at that level and need the same types of insights that those teams are that do. And you know, if you're making a decision about like lockdown or policy making, you might need some input from a model like yours and a team like yours, and also 5 other teams that are looking at the economic impacts and all of the other, you know, sort of implications. And there's there's a lot of challenges around how all of this fits together and how to address all of the needs in this space. So I really appreciate the sort of deep interaction that you're having with these teams, getting their data, doing that data curation, going back and forth at like an interpretation of the model and what it means and how it should be put into, you know, some sort of decision. And also, I'm also thinking about all the other teams that don't have the opportunity of that level of interaction that still need some sort of input about what they should be thinking about and how to address their needs.
Yeah, so one example on that, just very briefly. So there's the government, Mexico City government officials put together these weekly calls that they invited us to join, and then they're like different smaller groups of modelers putting different types of models to try to help out, which we have these conversations on what assumptions you made, like what technique you're using to calibrate, what data you're using, how you're using it. And that's trying to get to that point. Some of them are just interesting as an academic exercise. For us, I know that it hasn't been the case. Now we would like to make it a little bit more academic, so we can just put all this stuff out, but it's mostly like being in contact like constantly with decision makers, their needs, adaptation of the model, evolution of the model, but try to get at, try to like spread like the information and knowledge that we currently have with other colleagues. So Jeremy.
So I think the other thing is also, which is by working in I mean, you're absolutely right. Like there's no way, time, data for a variety of constrained resources, there's no way to work in every jurisdiction to answer questions at all levels that all people want. But one of the things that we've been doing and started to do, and you know, there's a number of things that are going to be coming out, you know, in the coming weeks from our group, is to try to pull together some common lessons learned about what drives it one way or the other, right? So first of all, to acknowledge when it's likely that there's going to be heterogeneity. So an example would be around like school reopenings. And the conversation in lots of places to date has been around what people are doing in the context of schools themselves, like what interventions and precautions and whatnot. And what we sort of have done is to try to start to think about what are the community factors around the schools that are also going to matter a lot for the decision, right? So whether the community has been able to control the community level epidemic via consistent NPIs, and whether you have a good belief about whether they're going to kind of continue to be able to do that matters a lot for whether school transmission sets off a resurgence, right? You know, and similarly, the implication of that resurgence matters a lot. So in California, there are some counties where 30% of the population, so Tulare County, for example, is school-age kids, and then there's a factor of 2 difference in terms of the fraction of the population that's above the age 60 at the county level. So 20% versus 10%. So if you imagine a county that has lots of school-age kids, fraction-wise, and lots of older people, that's the one that you should be really worried about if you're not going to be able to maintain really good control. And so it differs, right? It differs actually even within, like if you think LA County, so LA County is 10 million people. Actually, it's not just at the county level, but in that way. And so by looking at a bunch of different jurisdictions, I mean, for you know, like you guys did stuff, Fernando, on sort of on kind of the difference in population density and sort of the rapidity of spread in some early stuff on the state level in Mexico. I remember, and we did that when we were doing some stuff on Brazil as well. So I think that's another kind of thing, right? Because I mean, you can build lighter models or other tools for those jurisdictions, but those models either need to leverage information from places that are data rich, or need to like directly, or they need to leverage insights in terms of, you know, be able to, so they can kind of comment on those sorts of places. And I think that's, I mean, I think you're right. That's like an area that is under explored right now. And is ripe, you know, for that.
Sorry, I just want to be conscious of the time. That they told us that the session will end in like right now, 12:45 Central Time. So just want to make sure that we don't get cut off and without saying proper goodbyes. And yeah, Diane told us on the chat. So thank you guys. I appreciate the time, and happy to continue the conversation, Aman, if you're interested. And I guess you're going to continue joining the SMDM annual meeting?
Yeah, I'll certainly join as much as I can. And I think somebody from my team, Nathan Poland, reached out to you already, maybe both of you, about setting up a time to chat. So I'm hoping that we can.
I think it was to Fernando. So I'm sure that will lead to good things.
Yeah, so I can also send you the invitation, Jeremy, so we can both join. So I'll send out. So yeah, okay, man. Thank you very much, Valeria. And I also want to thank you. So Valeria and they're also part of the technical team. So I just want to make that sure. Like, none of this work in Mexico City and Mexico would have been possible without them. So Andrea and Valeria, thank you very much for the fantastic work that both of you have done on this project, and all the projects where we involved on the COVID-19 modeling. Aman, thank you very much, and we'll be in touch then. Thank you, Jeremy, also fabulous. Bye-bye.
I think one thing that you mentioned in the other session, I think it's the same regardless of the situation in the country. This thing with when the testing capacity is low, it affects those with the lowest income. I think that's the same even everywhere here in Norway. Yeah. So
it's just that difference between it's how sensitive, right? It's the elasticity of that response. Yeah. That's a little more steep.
Because we have the same discussion here, but I think the consequences for people are much smaller here. Yeah. Because everyone are kind of allowed to have
sick days.
Sick days, I think it's 14 or something like that every year. And I think they even have more now this year. I don't know, but yeah.
I read that in the UK, they're using a strategy of you get paid the day you get a test. by the government. So if you need to take time off for a test, that you are automatically just paid for that day by the government for the test. And then if you test positive, you get 14 days of pay automatically. Not by your employer, but by the government. And so this idea of providing people a safety net so that the consequences of a positive test, we even saw this in the, it's hard to call it the first wave in the US, but there were reports of even facilities not testing some elderly people to avoid being labeled as a facility. Like this idea that the economic consequences to your organization of being labeled a positive organization, the consequences to you as an individual of being a positive individual, we've made these things, I think, so costly that any strategy we can do to decrease the cost for a person is already a risky healthcare situation, inconvenience in your household, potentially costly in your household. Anything we can do from the outside to try to lower those are going to help us get people tested.
Here, there's only been discussion regarding the companies because employees will not have any problems economically because they are supported by the system somehow. So yeah, I had another question. One thing I was wondering about, because you're working in universities, and now that you do this work for kind of the government, what there is some kind of trade-off between serving the government and publishing and all the other things that you kind of typically would have done. Is it a difficult trade-off? Because I talked with my boss. I have a 20% position here at the governmental institution, and my boss there, she's doing all the modeling for Norway and coordinating a team that does it for Norway. And they have very sophisticated models, but they are not able to publish or get it out there. They're just delivering reports to the government all the time, and
because they don't have time, or because intellectually they're not allowed to?
No, because they don't have time. So
time.
Yeah.
So
Lauren and I submitted a paper this week.
We did submit one paper, but I wrote an entire paper back in April that never got submitted. The deadlines just get, you're trying to do things too fast, and would say that paper was 90% of the way out the door, and I just couldn't pull out enough hours to do it. So I think the challenge here is not the, I'm experiencing no restrictions on my ability to publish from any of our collaborators. Some of them might, I've signed some NDAs on some data sources related to social distancing behavior locally. So sometimes the inputs I use for the most local analyses are different than the inputs in the published stuff. So the published stuff has a citable input that is separate. When I'm doing very internal stuff, we do have some analysis or some data from the local transit commission that is very detailed, from a local shopping mall that is very detailed, that gives us a little bit more information about travel patterns in the city. But I don't know that that's particularly interesting for a publication anyway. That's never the exact, the world does not need to know exactly what London, Ontario should do next Tuesday at all anyway. And so for a publication, I think generalizable insights are the impact. But the time to publish, for sure. Early on, I was like, there's so many papers here. And now it's like, there's so few hours in my life. So yeah, that just is how it is.
I published a baby.
She's peer reviewed.
That's very nice.
Yeah, no, it's been hard. I mean, and everything, right? Like kids were home, we were doing this. I basically did nothing else other than look after a toddler, be 8 months pregnant, and do COVID modeling with the state.
So
and I think as a land grant institution, though, I think the University of Minnesota, that it is part of the mission, even though some people, certain faculty members have it more explicitly in their position than I do.
So Eva, as you think about the next 6 months or so and continued sort of, I was going to say support, but that's not the right term, continued engagement and leadership on this work, you know, from conceptual thinking to actual programming to communicating about it with us. How will you be able to manage that, and what will you be not able to do? And do you have the support from your boss and your boss's boss, who I know and who I can send an email to if that's necessary? But how does that feel for you personally and sort of professionally?
I mean, I think it's, you know, this is the time to be working on this, right? Like the time to be working on this isn't in a year, it's not, and the other stuff can wait. I guess I'm lucky, some of the faculty who were working on the modeling earlier on, who've since dropped off, had big, large programs that they were directing. So in some ways you're lucky that I'm at a point where I don't have a giant grant. I should have been writing a giant grant, but I do not have a giant grant. And so the fact that I don't have one, now won't have one, is, I think, you know, the reality, the kind of, that's the victim of this. But I think it's understandable, given that luckily it's been high profile locally, that I think the university is understanding of that. And then, you know, if not, 10 years. It's kind of...
but thinking about the fact that you are not writing that large grant, sort of what does that mean for you professionally? Or can you also, are you thinking about using this work to redirect maybe where you're looking for grants or where your career develops?
Yeah,
how
no,
your
for
career
sure.
develops.
Yeah, so I think it's about refocusing and thinking about, you know, hopefully, and this happens every pandemic, whether or not, I mean, this is a very severe one, but even H1N1 and SARS, this happened too, that there was a renewed interest in having these like models on call kind of thing. And so the extent to which, third time's a charm, we can learn from this experience to make a case that there should be funded modeling efforts that are meant to support local decision making based on our experiences coming out of this. And maybe the next thing won't be a respiratory disease, or maybe the next thing will be have to do with something else, or maybe there are ongoing things that could actually benefit from this decision making that have been lower profile. Then, you know, then we can do that kind of work. So I think there'll be renewed interest, hopefully, for support and an understanding that you kind of need to have some of the groundwork for this, like contact patterns. Like suddenly understanding contact patterns becomes really important. And so I think doing more measurement in normal times of like, what does it look like when school's in session? What does it look like when it's not in session? What do our businesses look like here, like locally in an urban setting versus in rural Minnesota? Like if we're really serious and concerned that we've implemented policies that are too strict or overly conservative for rural Minnesota, fine, prove it. Like let's get some data, let's measure it, let's see just how much more risk they could tolerate because of differences in how a disease propagates through those communities. Understanding that once it's there, it's spreading. So I think there are opportunities in that sense.
Yeah, I think the amount of contact survey information that is of high quality out there is shockingly thin. I think that's been very frustrating, how little there is sometimes available at a national level, not available at all at looking at these groups of individuals that we want to intervene on, like elementary school children, for example. And then separately, I think, so certainly that, But I think one of the advantages that Eva and I have, and I think some of the other groups that were funded through this initiative have, is that we'd actually modeled infectious diseases before. We'd actually modeled policy analysis in infectious diseases before, because one of the things that I find, where do the ideas come from for effective interventions, is the modeling of other infectious diseases before, even not respiratory diseases. But I think the number of times in a meeting with hospital decision makers, well, I'll be like, well, this is like these types of interventions in HIV. And they're looking at me kind of strange because they don't see how close the analogy is. But the information we have learned through so many years of excellent modeling in HIV gives us information about the importance of targeting high transmission groups, in targeting marginalized groups, and the importance of early identification of people to prevent transmission. And so we have this language from HIV of using treatment for prevention. And so I've really tried without a Twitter account to make testing for prevention a hashtag. But I think that we can, much of what we have learned from the prior modeling of infectious diseases really applies here. And I think that when we've seen these models coming out of groups that have the mathematical skill to build compartmental models, like that, this is not mathematically beyond lots and lots of other disciplines. But they don't know the literature that already tells us the types of interventions that are going to work in practice in social science, right? So we know more about the health behavior. We know that if you stigmatize people, they don't change their health behaviors, they go underground. And I think that that comes from much of the work of our colleagues in MDM, and the fact that we have this collaborative community that keeps sharing information like that across disciplines.
One thing that they utilized here in Norway is the data from mobile phones. So they got data on, I think, more than half of the mobile phones in Norway and how they moved around. I don't know.
We have that. So Google
How
Mobility.
do they use it? Like, to look
What?
at changes, or because the problem with it is, like, you don't know if someone's moving around a lot. Are they going to like all the parks, you know, and going hiking alone, or are they like partying? they're bar hopping from party to party. So I think the issue with mobile phone data is how to translate that into actual transmission risks.
Yeah.
I thought the strange thing there is also, so Google Mobility has it's 3 weeks in January is their comparison, or 2 weeks at the end of January, first week of February. And so it looks like it went up quite a bit, that we essentially returned to normal, when you could visibly see we had not returned to normal if you actually left your house to see what the traffic looked like. But I think that it's much of their data was not sort of week of year adjusted compared to say last summer. And so part of this return was essentially just that we don't have the same travel patterns in January as we do in July. And so some of their graphs are a little bit misleading in that way. The other thing, still in when trying to compare two geographies, so Erica has a paper under review right now that compares across geographies in that way. And so I think that there you can still gain some insight, but across time within a geography is problematic because of these underlying changes are not well adjusted for. Locally, we got a second set of data from another cell phone carrier. And it was really like the volume of cell phones moving around or versus staying at home. And I think that too ends up being, it matters whether or not your kids are in the car. And here in the summer, all of the kids' activities were canceled. And so it's one thing for the parents to continue to be going out to grab groceries or other supplies and then to bring them home. It's another thing to be driving and dropping your kids off at these various places, having a whole bunch of contacts and then picking them up again. And not many 4-year-olds or 7-year-olds are carrying cell phones around so that they get counted in those types of data, right? And so it's like, what is the age at which people start getting counted? and how much is that affecting our contact structure in our society. And I think it's pretty substantial. So I feel like the cell phone data helps, but not quite. And the mall data, like the number of people in malls, like helps, but it's not quite. And the public transit data, like it helps, but it's not quite. And so we've got all of these, we are looking at an elephant in a room through very tiny windows, I think, when we're trying to figure out how people have actually changed their behaviors.
Just, I think we're almost finished. And just a small question: how has it been to collaborate across the borders? Because I don't think many of the other projects had this two-country aspect.
It's always better to model with friends.
Yeah, but
I
also
am Canadian, you know, so like,
oh, yeah,
I'm an ambassador.
yeah, because I think we hear all over the world, we hear about whatever goes on in the US and Trump and all these things, but we don't hear about much from other countries, only if they do something stupid, typically. So
yeah, and only if they do something stupid in a week where Trump does nothing stupid.
That's a good clarification.
Yeah. So sorry, Torbjørn, I didn't let you finish your question though.
No, I think I just think it was interesting because I guess at least my impression is that kind of the response from the government in the two countries have been different.
But you do have a lot of local variation. So I think what's interesting is when Lauren and I were talking about when we finally realized we were both working on this, when we like came up for air, I feel like there was a long period of time where we weren't talking, and then it was all of a sudden, wait, you're doing this too? We were working with the Minnesota Department of Health, the state level, and Lauren was working at the local level, and she was working with the hospital. I was like, oh, well, we worked with public health, and she's like, they won't talk to me. they don't like my message. And so also just the like openness for who's willing to, who you're even just connected to, who you're in the room with, and then also who's kind of hungry for this kind of insight and knowledge versus who is not. And that varies even in Canada. So even if, say, the Prime Minister might be open to these kinds of things, there isn't, modeling at a national level is only so useful. And then within the localities, different localities have different attitudes, and each province is different, just like each state is different here in the US, and even cities versus other jurisdictions.
I think what we've seen covered in the US news is that some jurisdictions are certainly using evidence and evidence-based decision-making, and Minnesota is an example of that. I think New York during their crisis, the fact that he had built up a team around him of experts that were going to give him different advice to inform decision-making was at least what it appeared from the outside. I don't know that the teams involved felt that way, but certainly it looks like there was an attempt to adhere tightly to the evidence. Here in Ontario at the provincial level, I think we've gone through waves where it looks like they're adhering to expert advice more or less. Certainly at the beginning, there seemed to be quite a bit of adherence. I don't know that anybody in Ontario thought this is how our premier would have responded. I think we thought we had elected a Canadian version of Trump, and then he turned out to go to the University of Toronto and asked for experts. And so that was surprising. Here at a local level, I would say every single level has its own challenges. So at the hospital, that it's not that everybody hangs on every word of advice, but certainly the interest in being informed, in hearing this perspective and then hearing other perspectives has been really high at the hospital. At the health unit, they don't need any additional advice. They are fully informed already, and so they don't need to hear. The university level, I'm welcome to talk to anybody I want to, but they themselves feel fully informed by the health unit, and certainly don't publicly want to go against the health unit. And so now in a very subversive way, I'm doing presentations to groups of faculty and faculty leaders but the leadership has basically said, like, until you convince the health unit, we don't need to hear more from you. And so even at this like local level, the decision making can be so fragmented. And we see that carry out into the clinical outcomes. Here, our counties sometimes across boundaries that don't make geographic sense. I seem to remember Stephen Colbert informing us that American boundaries also don't make always a lot of sense. And so we had a huge problem here where people were working and living in different counties. I do not live in the county in which I work, and that results in a contact tracing nightmare because it's nobody's job to contact trace you. And so those types of fragmented structures in our decision making and our policy making and our abrogation of responsibility are very frustrating.
So where did you graduate from?
I did my PhD at MIT.
Oh, okay. And who was your advisor?
My advisor was Charlie Fine. He's more of an ops strategy person.
Okay.
There's a bunch of people who do the more modeling and even some of the medical decision-making work. So I knew of their work, but.
The MIT's set up a little odd, isn't it? It's the Operations Research Center, which is not really a department. So I don't know how the teaching works and whether it's set up like that, or how the PhD program works.
Yeah, the ORC has its own PhD program. I was actually in another PhD program that was also not a department called the Engineering Systems Division, which has now turned into the Institute for Data, Systems, and Society. One second. And the reason I was in that one was because its emphasis was more on the society's interaction with models rather than the sort of methodological developments, which is where I wanted to be. But most of the faculty in each of those places have another appointment, like they're in the business school or in the civil engineering department or somewhere else appropriate to their expertise.
Right.
So then the teaching comes not through the ORC, but through whatever department they're a part of.
Okay, all right.
All very complicated, but it seems to work.
Only name that comes to mind for me right away. Oh no, there's a couple names. Well, Larry Wine is there. Is he still there at MIT? I believe he's there. He used to be.
No, I don't know him. That doesn't mean that he wasn't there because I wasn't part of the ORC, so I only know some of them.
Okay.
Yeah. Oh, yeah, that's a computer. It's a very old computer, but it is a computer. Yes.
So do you have a full-time nanny, childcare person?
No, we should. Over the summer, we had somebody who was a teacher, but had the summer off doing childcare for us. And then the kids are now in a private school that is open. And so normally they would be in school right now. But we had a parent with mild cold symptoms, so we're not allowed to send our kids to school until we get the results of a COVID test. We're very confident it's not COVID, but nevertheless, we're not allowed to send them, which is fine. I'm not complaining about that. It's totally fine, but it's very disruptive to our ability to work, obviously.
Obviously, right. So. Boy, that's the problem with schooling. So the older child is what grade, or is he preschool?
He's in kindergarten. Yeah, he just started kindergarten, which is part of the reason we scrambled to find him an in-person school, because it's just so hard to start school for the first time online. And our public school district is all online. And so once we heard that in July, we started looking around for small private schools that would be open. So.
This is the DC area?
Yeah, we live in Fairfax, Virginia, so just outside of DC.
Yeah. I visited George Mason once.
We're really close to George Mason.
Right.
Actually. It's too bad that I don't work at George Mason because I would have like a 10-minute commute. but,
Oh, yeah, that's good.
but yeah, it's a really nice area. And my husband works farther out, so we needed to pick somewhere. I work downtown at GW, and he works out in Manassas, and so we're kind of split the difference.
Okay, all right.
I just wanted to give you an update real quick. Some people are not realizing that they had to leave other webinars. They're thinking they could stay in them and it would start into the next session. So we are having people joining in late into others. Just wanted to give you an update.
Okay, but it's been 10 minutes. Well, anyway, so yeah, so we should continue, you're saying?
If you will give it just a few more minutes, I just saw 4 attendees arrive into another session.
Yeah.
One of them being the speaker as well. Just didn't know that they had to switch.
Right, right. Maybe that's, I don't know. Maybe it should have been arranged so we just stay in the same session.
I'm not the organizer for that, unfortunately,
Yeah.
but I'll definitely write it down for feedback.
Okay. Thanks.
All right.
Sure.
Yeah. Maybe we do.
And I haven't forgotten you. I'm still watching for participants to arrive.
Okay.
Okay. It's not a problem to hang out. It's just that it doesn't seem, I don't know. So I'm not very familiar with this conference. I've never attended this conference before. What's the what are the areas that most people work in?
Okay, I just got clearance for you guys. Whenever you want to shut it down, that is up to you. I'm going to pass you the co-host. So when you leave, it will give you the option to end for all.
Okay, thank you.
Good. It's a wide variety. I mean, there are behavioral people which would probably not interest you at all. And there are, what other kind of people are there? There are modeling people who do analyses of various kinds, cost effectiveness and other kinds of analyses. And I found the best thing that I got out of these conferences were these short courses. I thought that those, if you pick the right short course, maybe well, even if you want to know, say, more about cost effectiveness, there's probably a short course. Those were the best things I got out of this conference. It's because otherwise there's so many papers, so many different areas. It's hard to pick out the ones you want.
That's a good idea, because I would love to, because I'm sort of a newcomer in this area, it would be, the short courses might be a great idea to sort of learn what does everybody mean by cost effectiveness modeling, because I can look at the words and understand, what I think they mean, but
yeah,
that's a great point.
Mm-hmm.
Huh. Is that the way that most people experience the conference, or are there sort of?
I think so. No, I don't think. I mean, I think it's a proportion, but I don't think it's a majority. There's a substantial research component to what's going on here. So it's there's some people working on just decision model presentation to users, and best ways to do that. It's all kinds of stuff, really. Wish I could be more specific, but it's been a few years since I've been to one of these conferences. Anyway, so I guess we can shut down then, right?
I think so. That would allow me to manage my children a little bit more appropriately. But it's been really nice chatting with you.
Yeah, thanks. And it's good to meet you, and I wish you the best on your project, which sounds really interesting and even challenging. So. Okay.
Some of both. All right. Well, thanks a lot.
Okay.
Bye.
Bye-bye.
Fang Li, do you have any questions about the modeling?
No, I was generally just interested in your research and topic, and just want to join and listen to other experts and your team discuss about it.
Okay. Well, great to have you here.
Yeah. How are you doing? And Elena and Natalia. Nice to see you guys here.
Me too. Good. pretty good. Excited about the SMDM. So I've been really enjoying it today, and yeah, so that's really great to see everyone, and yeah.
Yeah, same. Nice to see you, Feng Li. Like, it's a pity we can't meet in person, but it's great to see all these familiar faces now here at SMDM and Connect. So it's great.
And you have a beautiful background.
Mm.
And say you, we can't see you, but do you have a question for us?
Yes, I try to, okay, it's a better view here.
Yes, now we can see you.
And I really like your talk, especially on the graph, the implementation, and but I forgot what is the other part. But they really intrigue me about another question that I read some article before, but I did not really see lots of research on this, is the value of the implementation. I think it is one step after the value of information analysis, but they really intrigue me, but I really have not enough knowledge to how to approach this. How do we make this concept that link together? So I'm not sure if this is a good right place to ask this kind of question, since you are you are the only person in all the COVID-19 modeling group mentioned the implementation turn. So I think I might be raise the question here, see if I can get some insight here. Thank you.
Yeah, thanks for the question. Yeah, so we are actually developing those ideas right now on how to merge those two together, and we're struggling a little bit with it. Thank you. That's the graph that we're talking about. So this was our initial idea on how we could present and make that trade-off between the foregone benefits due to delayed implementation versus, the benefit that we would get from doing a new RCT. But in all honesty, I need to go back to those papers on the value of implementation. And they're from the Carl Claxton group, who also wrote the initial papers on the value of information, to see, how did they do it in those previous papers. And I just realized, today actually that with the discussion going on, that we need to go back to those papers and read them in depth and make sure that we really understand how they presented, and to see whether what we have, we envision right here with this graph, whether that is consistent with what they also present.
Yes, yeah.
There's also, like in the US context, some things get implemented, like Medicare will allow something to be implemented, but the evidence still needs to be collected. So that could be another thing, to make it more complicated, but that could be another thing to explore, is that there's some implementation, but the implementation doesn't stop the ability to collect more information about the point estimates.
Yeah,
that's one of the quadrants of the graph. Seiki, could you just put it up again? You still have it there?
I think it was also suggested like that by the York team, that they had like all different strategies. One was to implement and like collect further information.
Yeah.
But it's the implement and do more research, as in those who it's being implemented on, you can collect information from them, as well as like there could be a way you would continue to do more research that would possibly be disconnected from like implementation that's real practice.
Okay, but then we're talking about research, more like observational type of research, post-marketing type of research. Yeah.
Right.
Yeah. So that would be different than doing a randomized controlled trial, of course. Yeah. But then we'd have to look at what is the benefit of doing post-marketing research versus what's the benefit of doing another randomized controlled trial.
Right.
The thing that bugs me with all of this is that if you decide to implement, but you also feel that you still need to do more research, then it's going to be really difficult to randomize patients, because patients are not going to want to be randomized because they're going to say, well, for example, the FDA has already given an emergency approval for remdesivir. So if I were a patient and I was hospitalized, I don't think I would want to be randomized at this point. I would want remdesivir.
Right, right.
Yeah,
Exactly.
true.
Ethics are
But then on
big.
the same time, like apparently the results weren't clear enough to move all the way to the bottom right corner, like implement and stop doing research. So there is still this need for this information apparently.
It depends if there will. Yeah, sorry, you wanted to.
No, go ahead, Natalia, go ahead.
Yeah, I just wanted to add that it depends if there is another alternative that they could receive and when the effect is not clear, because then people perhaps would be more willing because if you have different treatment alternatives. But when it's clear that one is much or like shows much better effect so far than others, I agree, then it's problematic to encourage people.
Yeah, but then I think it comes also to like what was in this session, like this morning, like how do we communicate these things about, like, do patients always believe that a treatment is beneficial to them? Well, sometimes I think the point of like that it can do a lot of harm gets less attention, and maybe especially when we're focusing on COVID therapies, like it can be so have such a huge consequences that people are like, okay, let's give me something to make sure I will survive.
Definitely. And like, because we are not thinking like there can be also adverse events, right, of the treatment. So like actually it may be more harmful than beneficial. So at some point we don't really know that. So it's, yeah.
Your team is focusing on the US context, but you're in the Netherlands. So how are you thinking about the global context, in terms of acquiring more knowledge that is valuable in a value of information context, and then being able to distribute that knowledge in a way that has global consequences? How are you thinking about that?
Yeah, so at first instance, we're thinking USA because the USA has right now the largest number of cases. So in that sense, I think it would be most useful. But I'd like to expand to a global context, since but the most important part of going to a global context is, well, first of all, the shift in costs, which is going to be very different. I mean, I've done previous in the past, we've done cost effectiveness analyses and done a US perspective and a Dutch perspective and an English and a UK perspective. And, the costs in the Netherlands are about 1/6 of the costs in the US, sometimes 1/10, depending on what it is. So the costs would definitely have to be adjusted for that. But then the numbers of patients, so the numbers that would forego benefit and the numbers that could benefit from a new study, of course, would be much, much larger if we take a global perspective. And the other thing that would need to be adjusted, which is also very tricky, I'm not sure how to tackle that, is the willingness to pay, since the willingness to pay is going to be very different across the different countries. So that is to be revisited. We first want to get the model to work, for the US, and see if we can stay abreast of the results coming out. I think that's challenging enough as it is.
It may be that there's room, just like we saw with the last session, last breakout with David bringing in the Spanish study for vitamin D. It may be that there's still active research in some other country that can be fed into the model. So even if nobody in the US would be willing to be randomized anymore, it doesn't mean that in other country contexts that they would be at the same point in time in terms of their equipoise on running a trial or not running a trial.
Yeah, and so in general, I think the hazard ratio of a treatment effect is usually generalizable to other settings. What's not generalizable are the costs. That's very clear, and the willingness to pay. Sometimes quality of life is different across countries. And then the basic cohort on which the natural history is based, that is also a big question, of course. We're using a UK cohort now because it was the best data available and the largest data and the most detailed report. But there, we're making the assumption that that's a reasonable cohort even in the US context. But there too, we could question whether that's reasonable and whether we shouldn't be finding a cohort in the US.
Right.
One approach that the World Health Organization used to tout as part of their global cost effectiveness approach is to use the GDP per capita either 1 or 3 times that. They're not touting that as much anymore, as best I can tell.
Mm-hmm. Yeah, so even if we do choose that, because that would be a reasonable thing, use the 3 times GDP, I suppose. But then we have, how do we combine that for all the different countries? So then we'd have to do country specific and then add it all up at the end or something like that.
Yeah, I would even say that we would have to interpret it country specific, because VOI is so dependent on willingness to pay threshold.
Yeah.
I was bringing up the other countries in some ways just from the perspective of the question that Chaizu was talking about in terms of implementation and continuing to have research, that there could be continued research going on that would be able to be useful for that's, I was constraining it some.
Yep.
And I also think this point with cohort is very important, because even the healthcare quality can be so different across countries, and this can also have a huge impact on the outcomes and everything.
Yeah, I mean, the epidemic is being modeled per country, and then sometimes they're going even down to smaller levels of each country, depending on which predictive model you're looking at. But you're quite right. I mean, the ratios of hospital beds or ICU beds per capita vary tremendously across countries, even within the same income group, whether it's low, middle, or high.
Yeah. Yeah, so Stancha, what do we use for the ICU per day? Do you have that, or per week, or per whatever?
I'll look up the numbers, but we've used the ICU hospitalization rate from the UK cohort.
And but I mean the cost for the ICU stay?
I will look it up, but it's quite high. I think it's between 3,000 and 6,000. Let me check it from.
Per day or for total ICU stay?
Per day.
Okay. Yep. Okay, Kathy, I don't know how long does this session go for, by the way?
Yeah, because there's sort of an offset of 10 minutes for start. I'm not sure. I'll look. I don't think it's too much longer, but
session at 8 o'clock where I have to be, and I'd actually like to go and have a little bit of dinner.
Yeah. I think that's really fine. I mean, unless the only person who hasn't had a chance to say anything, Bob Beck, did you have anything to add or ask about?
I talked a little bit before you got on. So
oh, okay.
We're fine.
Okay, great. I was hanging out in the other room. I re-entered the other room.
I just wanted to check to see that you got what you needed, or if there's some follow-up you wanted to make.
Sorry, you're asking me, John?
No, I was asking to see you.
Sorry, I was answering a message. So can you repeat your question again?
No problem. I was just asking if you, we gave you a variety of answers to your question, and I wondered if you had any follow-up to that we didn't address.
Yeah, I think my first thought is, okay, I really need to go back to read all those papers that Miriam mentioned, and then to have a better understanding how can we really tap into that, because looks like there's a lot of computation.
There's a lot of computation involved with
Yeah.
value of information and value of
Yes.
implementation.
Yeah.
lots of numbers.
Yes, that's the number. And then I remember recall the first time I read the paper of a value of implementation. It's like, oh man, how I get into. So, and then I really have a trouble understanding the concept. So I just put it aside. And now it looks like it become a more important. Like I really like the point that Miriam mentioned that. So how to capture that we need to implement immediately, but also at the same time, we need to do more research. And then I was spending my hair around these two concepts together because based on the value of the information analysis, that if the expected value is greater, we need to do more research. So we postpone the implementation, but now it's a different case in the real world. So yeah. I will agree. I need to read more and then the more in terms of this. Yeah, but I really appreciate all the great insight and how to look at things from different perspective and also the global perspective based on the value and the cost, and then also the restriction or dynamic of a political situation. So.
May I ask a question if time still allowed?
Oh, please.
Yeah. So I was curious about like how should we think about the maybe subpopulation, like maybe like people with different age, like how should we prioritize like across different age groups, like within maybe a region within a country, since the vaccine won't be like widely available, like probably for half of a year or a year, even it's developed well, or like or maybe like the symptoms or the health outcome will be vary a lot across, I assume, across different age groups. And how should we think about like collect more information and like implement vaccination programs?
Yeah, so I'm not quite sure. I understand your question about the vaccination part, because that's not really what we're looking at. We're really looking at the therapy part. Although we could theoretically take the same concept and start thinking about RCTs for vaccination, but that's then it really, I think, would involve also looking at SEER models, so the regular infectious disease transmission models. So we're really looking at therapy once somebody has COVID, or potentially things like the vitamin D as a preventive therapy from getting COVID. But taking your other part of your question about taking into account different groups, right now we don't really make a distinction between the different ages, sex, and race, and anything else. We just take the average. The only distinction we make right now is the distinction between those that are hospitalized on a regular ward versus those that are hospitalized in an ICU. We could conceivably, include different age groups or run the model for different age groups and different age sex groups. That is possible, but so far we haven't done that yet.
I think one thing that I would just add, that if we would do that, there is also this like equality issue, like providing treatment to some patients, not to others. So that would be, of course, a bit more problematic as well.
Go ahead, Elena.
Oh, but I was like, would it be like related to the vaccine? Like Feng Li said, like if there becomes a vaccine available, not everybody in the world can immediately be vaccinated. So some groups already have the vaccine, while others are still waiting on it. And for those that in the meantime get like infected and end up being in the hospital, they still need to have a treatment. And then there might be like subgroups that have vaccines and not, and ages, and all of these things could be really relevant to take into account. Not sure how to do it, but it's important to think about
access
that
to treatment, because we are now assuming that we don't have any issues with like access to treatment, and there could be like we have too little treatment to treat everyone. but we just said that, yeah, we don't really want to look into that. Like at our last meeting from, I remember that Miriam said that, yeah.
I mean, the presentations in the last session earlier, there are several models that were looking at vaccine, in particular, perhaps what you're thinking about, the UMIT model that Beata presented, where there may only be a few hundred, doses of vaccine available. They're trying to explore with their Austrian government, who are the few hundred people that we should allocate those vaccines to. And I'll say it's a large topic of conversation over here in the United States. Do you give it to we know this is a age-related mortality. Do you give it to those who are at highest risk for dying? And to what extent do you want to make sure your first responders and healthcare providers are protected from it? And then, where do the others fit into the priority list? Because whenever a safe, effective vaccine becomes available, it will not be available to everybody within, as best I can tell, any country. So there will have to be some prioritization. That's really not, I would say, as Miriam said, the focus of what we're exploring, which is the value of information.
I think there was a paper about that, like cost effectiveness, and I think they modeled when vaccine, like it's not what we are doing, but like in addition, just like a comment that I think that they model that vaccine will be available to everyone in 2023, something like that. So, and they like estimated as well. I have to find this paper. It was quite.
Miriam, you should probably go and eat. We don't want you to pass out.
I was thinking that too. It's so, you guys are really late there, and we did hit the end time. And
thank you everybody for your suggestions and questions. I really appreciate it. And I need to go to the next session. So
great.
Well, there.
Thank you all. We'll keep seeing you at the meeting. This has been great. And I see the last question from Shima and a mention also. So thank you for adding that. Okay, take good care.
Yes. Bye.
Bye all.
Hello, Scott.
Greetings, David and Ava.
How are you?
I'm doing all right. There's a virus going around though.
Yeah, yeah, I've heard. Get your flu shot.
I got my flu shot, and I got my shingles shot too. So I'm
okay.
I'm covered.
Oh, that's great. Thanks.
You got the new one. I guess are they even giving out the old shingles vaccine anymore?
Well, I got the new and improved version, the shingles.
Yeah, that's a better one, I think. Yeah.
But I have to go back for my second one.
Yeah.
I'm getting.
So I guess, yeah, aren't we all? So I think I'm the moderator here, so I'll just, so thanks Scott and CCC Castro and Gabrielle. And so we have Ava here, who is with actually Gabrielle and Cameron are part of Ava's team here looking at social determinants of health, and I think it's a really interesting project to look at social determinants of health and how we as SMDM modelers should be thinking about social determinants of health. And they're doing some really interesting things, doing the lit review, as you saw in the previous meeting earlier, and then surveys of decision makers and modelers, and trying to figure out how we can all sort this out and develop some recommendations for how we actually do that. Yeah, I guess Ava, I'll turn it over to Ava, see if you have anything else you want to add to that, and then we can just open it up for questions.
Sure, I just love to open it up to questions actually, because unless you wanted me to go back over the projects,
I think Scott was in the earlier meeting, so
yeah.
I'm embarrassed to say I had a conflict, and so I was not able to see Ava's brilliant presentation.
Thank you.
I was able to hear Harvey Feinberg speak, but I didn't hear the other talks.
Sure.
Ava, if you want to give us the 3-minute version,
No problem.
I'm sure Cameron and Carmen will appreciate it, because I although I've never met Carmen in person, she's a new colleague at MD Anderson, but we had a virus and we can't see each other. So I can't even see her on the screen.
No problem. Okay, welcome, Cameron. Carmen, sorry, Carmen, because
Yes.
there's also Cameron. Hi, Carmen. Welcome.
And hi, Scott. It's good to finally meet you in person virtually.
We have to travel 3,600, thousands of miles virtually to be in the same room.
Right.
Ava, this is your show. I'll shut up. Go ahead.
Sure. Oh, no problem. So the 3-minute overview. So with the COVID-19 pandemic, it became pretty evident early on that social factors like race, ethnicity, income, sort of occupational vulnerabilities were highly related to risk of contracting the virus, morbidity and mortality. And that evidence, emerged, some early evidence at the county level in the United States, looking at counties with a large percent of African Americans compared to lower percentages, had higher rates of infection and mortality. And similar information kind of emerged from England and other countries. And so we were very interested in to what extent these phenomena were being reflected in infectious disease models of COVID-19, either in efforts to predict the pandemic and the magnitude of it, to appraise intervention options, and perhaps look at targeted interventions, and then to understand and predict the impact on other health conditions and the health economic impacts as a result of COVID-19 or the shutdowns and other interventions. So we have a suite of projects that we're doing, a systematic review of the literature, identifying published and archived infectious disease models to look at what types of models are used. Do they include social factors? How do they incorporate them? And we've tried to group those, looking into those that are looking at outcomes like predicting the pandemic, impact of interventions, and so on. And then we're conducting 2 separate surveys, one of decision makers to understand what types of questions related to socially vulnerable populations they would like to see addressed with models, and interviewing modelers to find out, surveying modelers to find out what are the barriers to incorporating social factors into models. So I'll stop there. That's the overview of what we're doing. And our general hope is to emerge with some sort of preliminary guidelines. I think we wouldn't have enough time to engage the modeling community in a more extensive guideline process, but we feel like this could lead into a more extensive guideline process to hopefully improve our efforts as modelers at looking at these issues.
So Ava, so who exactly are the decision makers that you're talking about, and how are you doing the survey amongst the modelers?
Yeah. So the decision makers that we're talking about, it's a great question. So you've pinpointed where we are, I guess, debating amongst the investigators right now. We have in our minds a couple of groups or ways of thinking of decision makers. One is that those that are already connected with modeling efforts. And so in Canada, we have decision makers and modelers connected at academic institutions and provincial level decision makers, federal decision makers at the Public Health Agency of Canada, et cetera. The groups that are fairly easy for us to reach out to in order to survey. We have ambitions to reach group decision makers that are not necessarily engaged with modeling efforts, like those that might work at smaller service organizations that interact directly with low-income groups that interact directly with and serve racial and ethnic minorities, to survey them. We are trying to be realistic, though, about the scope, and we will likely be looking at sort of the more macro level decision makers because of the time constraints that we have. I think your second question was about the modelers.
Yeah, is it just our group of the folks that
right
you heard today?
No, the repository of decision modelers, that's one of our sources for the survey, who we want to send the survey out to, possibly SMDM members. So the SMDM CDMI group is very open to that. So you might get an email message from us. But then we want to use the networks of our investigators. So our co-investigators include people from the US, Canada, and England. And so through those networks, we want to try to expand and survey modelers that way. What are your thoughts?
Sounds like you're going about it the right way. I'm not in the business of modeling, so I'll ignore your questionnaire when I get,
okay,
or at least modeling COVID.
Okay.
But it sounds like you're going about it the right way. I mean, certainly you can open it up to, you can use the SMN, I assume you can use the SMDM databases if you want to go for everybody in that sample that's there. That shouldn't be that hard to do. And I'm sure that's not a problem.
Mm-hmm.
The decision makers, that's a bigger challenge though. What that universe is. That's why I was curious of your thoughts, because I don't know how to make that happen.
Yes, it is a bigger challenge. And I think, again, it depends on the sort of the level of the responsibility, level of decision making, and proximity to modeling efforts, at least for us. That's one recruitment strategy that we could use. Yeah, so it is a challenge.
And in the US, I couldn't honestly tell you who really is the decision maker. So
okay, that's interesting.
So we got bigger problems.
Right. Yeah. So what is that landscape in the United States? You've got sort of this world-class advisory bodies like the CDC, but what's happening at state and county levels? What are the what is that landscape like?
And I'm wondering if that's your best way to go. David has a brilliant thought, but we can't hear you, David.
Oh, I'm sorry. Can you hear me?
Yep.
Yes, now we can.
One interesting thing. So social determinants of health has been a big focus in healthcare, obviously, recently. Right. And Epic, the electronic health record, has over a 50% market share. And one of the fascinating things is that there are very high costs to deviating from whatever they recommend about pretty much anything. And so interestingly, Epic has become a significant driver of how the US conceptualizes social determinants of health. Now they have advisory boards, it seems fairly random how you end up on them, but it's really interesting. I mean, we had a whole big retreat about how our institution would measure social determinants of health as part of interventions and evaluation. And when push came to shove, it came down to the hospital had very high barriers to doing anything that Epic didn't want to do.
Would you be able to describe Epic? I'm not familiar with Epic.
Oh, Epic is the largest electronic health record company in the United States. They have over a 50% market share.
Okay, and they've got standardized
templates. They have
templates,
something called, I think, Healthy Planet, which has a module in it. for measuring social determinants of health. And it has a variety of domains and some questions that are some combination of things they made up and based on the literature and what, you know, that ask in various domains. And if you use their template, then your data ends up being benchmarked against, you know, a bunch of others. And it's a very, very small step from that sort of benchmarking and payment models, regulatory issues, and a bunch of other stuff.
And what are the benchmarks? Are there things like, are you meeting targets equally as well?
There aren't
certain
such
racial
for
subgroups?
social determinants of health right now, and there's been a pretty active debate in the US about how to use them in payment models. But as you know, the first step in anything is data streams. And the data stream is heavily driven by practical concerns, which are heavily driven by Epic.
That's interesting. As I was mentioning to David in our first breakout session, in Canada, we have a very different problem where for a range of reasons, we have not been collecting data on social factors. So in clinical encounters, we don't collect income, we don't collect race, we don't collect ethnicity. For a variety of reasons, it's a little more complicated because we have immigration from all around the world, and our categories, you know, we have probably the biggest non-majority category would be like 5%. So we've got so many. And then, so it's a more challenging that way, but also a little bit of willful ignorance of the importance of those factors on health outcomes. And so COVID-19 has been a major driver for us to actually begin collecting that data.
Yeah, and I don't know how things have changed in the past few years, but I remember not so many years ago that the use of electronic health records in Canada was relatively behind the US.
Very much.
I don't know how much progress has been made, how quickly, but that's probably part of the landscape too.
Yeah, so the progress has been slow. Yeah, so this is not my area of expertise, and I'm not a clinician, but we're still pretty far behind, and we have very poor standardization. So, you know, hospitals each have their own system. They don't talk to each other, and it baffles me because, you know, we have basically provinces that pay for 70% of healthcare. So with the power of the purse, I'm really confused as to why it's not better integrated.
Yeah.
Can I say something real quick?
Yeah, Cameron, welcome.
I work with Dr. Baptiste and Dr. Ali. I came from Seattle, Washington. I used to work at Fred Hutchinson Cancer Research Center. So Epic was something that, as a clinical researcher, it was very much a part of my life to use Epic. And Epic Care was such a helpful tool to use as well to get access to patients' data that's from if the patient's from Hawaii, it was super easy to get access from the patient information. But like when I was talking to colleagues when I came to Canada, they would explain to me it's really difficult just to get information just from the hospital down the street, and it's just like what Dr. Baptiste just said about how different hospitals have different system, and slowly but surely they working on trying to get access to make a partnership between everyone from all the hospitals. But yeah, it was very interesting talking to one of my colleagues because they were like, the hospital they were working at was talking about the potential of using Epic, and I was very much telling them like, Epic is a very helpful tool for them to use just in general, so you can easily use everything. So it was just ironic that you guys was talking about it, because I was just thinking about, I would just have that conversation with one of my colleagues just a minute ago. So yeah, sorry to interrupt, but yeah.
Yeah, no, it's a big problem, and I should highlight probably the one exception is the province of Alberta. They do have an integrated medical record system across the entire province that integrates hospital, primary care, specialist care in the community, etc. But I think they're the exception. That's my sense. And at least in Ontario, there's a bit of political history around that. In the 90s, when sort of all this technology was emerging, the provincial government at the time was forcing hospitals to merge. And I think the hospitals specifically adopted discordant medical record systems so that they would have a greater difficulty merging them and closing, closing hospitals and that sort of thing. But then we never quite recovered from that. So that's a window into our problems. Yeah. But we're just beginning to collect, for instance, race and ethnicity, but it's imperfect. So currently in the province of Ontario, which I know the most about, in the public health units for people who test positive for COVID-19, they then will ask them to self-identify into one of the racial or ethnic groups that they've pre-specified. So that's really, suboptimal. It's only those who test positive. And then also, because of the large amount of mistrust around the questioning, I don't think they have very high rates of completion of that data. So yeah, we do a bit better with Indigenous health, not so much in terms of the health of Indigenous people, but in terms of the discussion about the sort of historical context and the challenges with the health system and health outcomes, and data collection is a little bit better. Mm-hmm.
And I think a lot of this kind of ties back to the the COVID-19 analysis you're doing now, and I think it brings up a challenge, I think, for you is when you're looking at a study in Canada versus the US versus the UK versus Japan or something like that. They might have different definitions of how they categorize these social disparities.
Absolutely, because of each has different population distribution, different by definition minority communities. So those challenges, they're significant. I think that we expect most we expect the most common social factor, as we're defining it, to be investigated is probably going to be age. Perhaps things like sort of neighborhood and household crowding, right? But I expect a lot less on racial and ethnic subgroups. But we are just we're beginning data abstraction, so we can't yet answer that. I'm just giving you my suspicions.
Yeah, and I think some of that might kind of bubble out of what you see in the studies.
Yeah, absolutely. We'll be able to answer those questions more precisely in December.
Yeah. Well, I think we're running near the end of our time. Does anyone have a final question for Ava and her team?
Just good luck.
Thanks.
Just for good luck. No question.
Thank you.
Yeah.
Thank you.
Yeah. Well, Ava and Gabrielle and Cameron, thank you for sharing with us what you're doing and answering our questions, and thank you to the rest of you for attending. And hopefully you all enjoy the rest of the SMDM meeting this month.
Yeah. Thank you, David, for hosting, and thank you, Carmen, David Meltzer, and Scott for joining, and thanks Gabrielle and Cameron as well, who are on the team.
Well, thank you. It was good to hear your talk.
Oh, thank you.
Bye.
Great to see y'all.
Enjoy the rest of the meeting.
Thanks. Bye-bye.
What was the last question? Yeah, the question was, there's a lot of disparity, at least in Canada, with respect to who gets infected and in which socioeconomic class they are in. And so some of the, again, drawing from the work that we have or we have to do, some of it is related to the to understanding what, say that you want to vaccinate, and you know, you could take this maybe controversial decision to vaccinate based on, not on demographics necessarily, but based on these social disparities or socioeconomic status. And so that's why I was wondering whether this socioeconomic status or some form of income deprivation is part of the, would be considered as part of your baseline characteristics of these agents.
So again, now it's not, this was not yet part of our research question, because it would be quite, well, in our model structure, it would not be that easy to include that kind, because it would also have a big influence on the contact behavior, I would say, because that's actually the reason why this disparity is present, like they are more exposed or are have little access to hygiene measures or something like that. So that's like the problem. Because we do not have any data for that, well, even the contact data we have now is based on a study from 2013. So like having data accessible for contact behavior is very, very difficult. And so that's probably also one reason why we did not include it yet. We will, of course, include information for background morbidity or comorbidity, so to say, because this is very influential for our main outcome, which is essentially the COVID-caused or COVID-related death. So that's why this is an important feature, and we will include that. But this is a very...
That's what I think is a very nice point. So imagine in the end you have two different scenarios, and both do well with vaccines. The one protects the elderly people because they are the vulnerable group, and the one protects the healthcare workers because they need, you know, sometimes you say if you send somebody to war, you need to give them a helmet. So because we protect these people. So then there may be a trade-off in the end, which will say, well, if we send these warriors out, and that's not utilitaristically, that's not the best thing to do, but that's what we need, that's what we owe them, because you know, we send teachers to school, we send healthcare workers to the hospitals. Then you may come up with saying something, okay, we are willing to sacrifice a few deaths of elderly people in order to protect our healthcare workers. Or you say, no, we would like to maximize qualities or life years. No politician will say that, but that's what we will put on the table. It's a trade-off, and I think with respect, you know, there's also always, you have to include in your science vulnerable groups and ethics and all that. So what we decided is to, as Martin has said, to model vulnerable groups, not just healthcare workers and age groups, but comorbidities, and that's where we're currently struggling. You know, all comorbidities, all healthcare workers are just the most risky ones. So in that respect, yes. Because we can only model something, policies that would be doable afterwards. And nobody would say, you know, the poor people or the rich people get vaccination first. Nobody would do that in Austria. But what could be doable is, say, healthcare workers first, or people with a comorbidity, if I, you know, fantasy, with a comorbidity index of bigger than whatever. That's already questionable, right?
I mean, it's not completely unfeasible, like to have focused vaccinations for people who are, for example, working in post offices or working in slaughterhouses, for example. There had been a lot of clusters in these regions, partially because the virus spreads very nicely due to the humidity and the temperature. So this could be something which might be included in the strategy, but for the modeling part, we cannot. We need to make a cut somewhere, and that's the point where we do that.
Yeah, and also that it's a little bit a trade-off with respect to time, since you know we have to get our results by the end of the year, before the end of the year, and so at one point we also have to be pragmatic. But we have, we discussed this option on other socioeconomic status, since we see recommendations, for example, in the guidance or in the strategy published by the European Union, where they talk about other groups as well. But in this first step, I would say we don't do it. We just can't.
That makes sense. So I have one more question, but I would want to open the floor again to the people that are listening in case they have a question that they would like to share.
Or also maybe the others, they just want to share their background and way they are interested in. So it's also feel free just to chat. You know, it's not so.
We've been sitting in our office, in our rooms for too long. Some form of social interaction would be very, personally, I would be happy to hear another voice. I'm already excited to be seeing other people. You know, we haven't traveled for all these months, so it's good to hear other voices. So feel free to introduce yourselves or the reason why you were brought here without putting you on the spot. Maybe related to that, and until someone takes the courage to unmute, I would ask you, Beate and Martin and Uwe, how, you know, what was your experience with this grant? And I mean, we all had, anyone who did modeling within this period of COVID, I'm sure they've experienced these long nights of coding or writing or grant writing that, you know, suddenly, usually it would take a year to build something that you build within like 2 months or a month. Can you reflect? Do you want to reflect a little bit on the experience of this kind of intensity, high pressure, and also it's our time to have meaning, like to have as, you know, and policy influence, but at the same time are so short in personal and work time. So
I would leave that to Martin and Beate because they're the hard workers. I do have hard work too, and long nights, but not only with the grants. It's a lot of other people as department chair. So to answer your question, I would let go Martin and Beate ahead.
Right.
Yeah, it is an extremely challenging situation, especially when we were writing the grant. We, in addition, had homeschooling and everything.
Yes.
So I felt like, okay, I'm continuously working. I just had to make sure that at least, you know, a certain amount of sleep so that at least I can keep my brain working. Because there is a limit, and it just goes so slow that it doesn't make sense anyway. Exactly. And yeah, you have to be really, really disciplined. I felt like, I mean, I usually very disciplined, and I know what I need to do at which point in time. But it was even more, and you have to see, okay, what do I need to do in order to write a grant? To whom do I need to contact now? And then you know, that the process really works out. And in addition, you have the other projects that you plan to have, and that just run in parallel. And but it's also I would say a really motivating time because it brings people together that maybe would not have come together otherwise. So, for example, I always used many occasions where now we have this little networks for modelers in the German-speaking countries within the public health network. And I always try to bring up the questions that we have for the grant also in the other meetings, or we have now regular COVID meetings at our institute and things like this. So it is challenging, but it is also rewarding. And at one point in time, I usually run the meetings with the team, and then I usually ask the questions like, okay, this is what we have. Or from a pragmatic point of view, can we do this within time or not? So do we put it in the to-do box now, or rather in to think about and not to forget, maybe in a second phase?
Martin?
Maybe I can comment a little bit on the challenge. I think Well, I'm a little bit privileged because I don't have kids at home and a very patient wife, so everything is fine. But nevertheless, I think, well, to us, which we were the ones who have developed most of the or implemented most of the model, I think the most challenging part was, of course, in the phase before or after the first lockdown we had or the lockdown we had in Austria. So this was very, very challenging. And here, not with respect to grant writing or with respect to research also, but rather with respect to the policymakers. We were highly involved in the decisions made, and the decisions are usually made, well, 2 days or in 3 days, but not in 2 weeks or in 3 weeks. Everything has to be finished in 1 week, in 1 day, 2 days. And even if we had a deadline, the deadline was postponed, but in the other direction. So it was even earlier than announced at the first place. So this was very, very challenging. And in combination, there was the one thing Uwe mentioned, that modeling and simulation was very prominent in the media. So we had a lot of phone calls, we had a lot of interviews, we had a lot of television reports with us in the focus. And as a follow-up, a lot of angry calls from people who did not understand what we were doing, or people who hated us for what we are doing. So this was very, very challenging, not only with respect to hours working, but also psychologically, because there was I think most of us had experienced this point where we were not sure about what we were doing, and is this okay? A lot of lives are depending on our decisions, and a lot of people cannot cope with that. So these doubts and this psychological pressure was sure challenging.
I was thinking that like SMDM should have a therapy session for post-COVID, post-traumatic disorders for COVID. I mean, because the same stories that you're sharing now, exactly same stories we've heard here and in other places with other collaborators in the US, exact same stories, exact same calls from angry people and late nights. And one thing you mentioned in the beginning, and I think we have to close, but one thing you mentioned in the beginning is that you mentioned yourself as being privileged not to have kids. I think it's in a way the other way, like the people that have no kids at home lifted so much of the weight of the work that has happened in this in the early parts, especially when we had our kids at home. I saw it in our group as well. They stepped up and they took a lot of the work that, you know, some of us could not handle because of the kids. So you were not really privileged. You're probably, you know.
I don't know.
Anyway, I think it's time for us to end this session. Thank you again for participating. And you have any last thoughts before we close this?
No, I just have maybe one other remark. So we have talked about the hardworking people, and with Julia, we have one of our students here. So we couldn't do all this work and the grant writing and all the other help we get from our students. So Julia, thank you very much. You were silent, but you suffered too. And I think you should have the last word when we talk about the work. So thank you.
Feel free just to say something here on the.
Hi, I was silent because I was listening, but yeah, I'm working together with Beate and Uwe in the same institute in Hall. And yeah, sometimes are pretty stressful, but yeah, it's super interesting work also. And it's cool to be working on something that is happening right now and that the whole world is in it, and yeah.
And a crazy learning experience, I'm sure. Like, awesome.
Yeah.
Okay, well, thank you very much, everyone. See
Thank
you
you so
around
much.
again.
Thank you.
All right.
Bye. Goodbye.
Bye-bye. Thank you.
Bye.
Thanks, Martin. Thanks, Beate, and thanks everybody joining.
Thank you.
Yeah, and thanks for moderating, Pedro.
You're welcome. Bye.
I'm just trying to follow up your calibration method because I think I really need to understand this. So yeah, so well, I guess what you're saying is that you do like calibration for one parameter like each step? Like, so you explore the space for one parameter first and narrow it down and apply that to calibrate another parameter. Is that what you did?
So it's not one parameter. So the parameter we're calibrating is the transmissibility and then the contact rates in household, neighborhood, workplace, as well as this compliance to stay at home if you're sick, if you have symptoms. So those are kind of like saddle parameters, and we have ranges on those. So we created like 1,000 different parameter sets with these parameter different ranges and combinations. You can think of kind of like a grid. Right. So then we feed in each parameter set into the model. So the step one, as Søren just mentioned, is it's calibrating target is the R0 in the early stage of the transmission. So we're calibrating to local Seattle data. So sorry, the first stage is not super local. So the first stage is the R0 has some range from the literature, and the timeline is the Seattle transmission. So like in the first, I believe it's like 2 weeks or a month that we're running the model and with these parameters set to see what outcome would fall within the R0 range. Right, then we can select the parameter set with some goodness of fit criterion. And then, which I think is a mean square error. And then once we select the top parameter set that meets the R0, then we do a clustering technique to have representative parameter set. And then I think we found 2 clusters that both meet the R0 criterion. And so both could be reasonable representations of reality in Seattle. So that's stage 1. So stage 2, so Søren now use the top or the selected cluster, right? It's a cluster set.
Seven sets for the stage 1.
Right, so stage 1, we found 7 sets. So the second stage, we use those 7 sets, and we basically simulated the COVID-19 infections, or I think it's from February to June or to May.
Until May.
To May this year, right? So then using the known infection fatality ratio,